So welcome to this Retina UK information webinar. This is one of a series of webinars that we're holding, and we'll be delivering at least one every month on a different subject. So we're really pleased to have with us today Dr. Daniel Jackson. Daniel is a clinical research fellow working at Moorfields Eye Hospital and the Institute of Ophthalmology in London. He's currently undertaking a PhD with Professor Mariya Moosajee and works in the adult and children's genetics clinics at Moorfields. His background is in clinical ophthalmology, where he has almost completed his training in the Oxford training programme. He has a special interest in genetic eye disorders, including inherited retinal conditions, paediatrics, and glaucoma. So I'm also joined this evening by Kate Arkle, our Research Development Manager. And whilst Daniel is giving his presentation this evening, we will be collecting questions to answer at the end. So there are a couple of ways that you can ask questions. You can either type them in the Q&A section, which is at the bottom of your screens. These questions will be asked by the team on your behalf. Alternatively, you can raise your hand by pressing the Alt and Y key if you're on a Windows computer, or the Option and Y if you're using a Mac. We'll then ask you to unmute your microphone so you can ask the question yourselves. So please do leave your questions throughout the presentation, and we'll have them answered at the end for you. We will endeavour to answer as many questions as we can. However, any questions we're not able to get to today will be followed up over the next couple of weeks. So thank you once again for joining us. And without further ado, I'm delighted to welcome Daniel.
Thank you ever so much. And it's a pleasure to be able to speak with you all this evening. I'll just load up my presentation. Perfect. Yes. So, yes, thank you, Matt, and thank you for the invitation. So, I'm going to be talking about imaging of the eye and in the retina in particular. Now, this is a huge topic, and changes in imaging have revolutionized the way we have, we approach treating the eye. So, both in the diagnosis, monitoring you, investigating you, and also treating you. And what I'd hoped to be able to answer throughout this presentation is why we take retinal images, what images are taken at a typical appointment, how the images are taken, although I imagine many of the listeners are perhaps more expert at having pictures taken than I am, how we interpret them. So looking at the images, what do they mean? What do they mean for the eye doctor? What do they mean for the patient? And actually, how does this help in planning treatment? So I'm going to put this into a context of a typical clinical appointment. As many of you will probably know, an eye appointment is not just a simple wait and have a 10-minute chat and go. You're usually there for a few hours. First, you need to find the hospital, find the reception. I know in Moorfields in particular, it's a rabbit warren, which is very difficult to get to. You're then having to wait around for a little bit. Someone calls you in. You have to then read this chart, having to put this thing on the nose with lots of pinholes, which is difficult to hold. Someone might come towards you and check your eye pressure, put some eye drops, which invariably sting, and then your pupils become very big, so your vision becomes very blurred. After that, there's some more waiting and a bit more waiting, and then eventually you're taken into a room or lots of different rooms where you have all these machines usually humming in the dark. You then have to try and pop your chin onto the rest, keep your head forwards against the band. Someone's asking you not to blink. You might see green crosses. You might be asked to look in particular directions. You see lots of flashes. You come out back into the waiting area where your vision is even more blurred after all those things happening, and eventually you have your appointment. So what I like to do today is just perhaps just talk about some of these things that you would typically have done during your appointment. And I would say actually having the pictures is one of the most important parts of your eye appointment. And in fact, nowadays with eye clinic workloads, we are even moving towards just having virtual clinics where actually if you're stable, you've had some appointments with a doctor already, you just come in to have your pictures, your images taken, they're reviewed remotely, and then we will contact you with regards to the outcome. Now, to be able to talk and understand a little bit about the pictures that we take of the retina, it's helpful just to have a basic understanding of the eye and the structure of the back of the eye in particular, which I'm sure many of you are aware of. So This is really just a cross section of the eye. So the eye, you think of it like a sphere. It's about 4 to 5 milliliters in volume. The cornea at the front is the clear window into the eye, the part where, let's say, you would put a contact lens on. Behind that, you have your lens, which is like a clear blob which hangs in between these ligaments just behind the colored part of the eye, the iris. The lens, together with the cornea, helps to bend the light such that it hits the back of the eye, hitting the retina and giving you a focused image. Behind that, you have this jelly substance called the vitreous, which is important in development. Mainly water, but it is a bit of mainly a jelly type substance. You then have the optic nerve, which is the cable which relays all of this electrical information taken from the retina to the brain, so the brain can then interpret the image. And then you have the retina itself, this very, very thin layer. If you see with the compared to the rest of the layers, a very, very thin layer at the back. Behind that, you have the choroid, which is the layer behind underneath the retina, which has a lot of the blood supply to the eye. And then you have the sclera, which is the very thick, white, tough coat, which we all see. Now, when obviously we need light to go into the eye, it hits the retina, which is, as I say, a very thin piece of tissue at the back. It's approximately 150 microns to 400 microns, so less than half a millimeter thick. And if we were to have a look or take a photo of the back of the eye, this is what it would look like. So you see this nice sort of orangey sheen of the retina. You see this white circle, which is the nerve. So you see sort of a pinky area around the outside and a whiter area in the middle. You see all these red lines, red squiggles coming off the nerve, which are the blood vessels. So these are the arteries and the veins that supply the retina. And then you have this dimple in the center, which is the macula, which is obviously very important. I'm sure many of you know about it, but this is responsible for our central vision, our detailed vision, reading vision, and where we do most of our seeing. So any small changes that happen with the macula can have quite a big impact on a person's vision. Now, if you have a look at the cross section of the retina, despite it being so small, it is highly organized and actually very complex. We divide it really into the neuroretina, which is around about 9 layers. Underneath that, you have the retinal pigment epithelium, which is a single layer which helps to provide support to the photoreceptors. So these are the cells which help collect the light in the neuroretina. And then below that, we have the choroid, and then outside of that, the sclera. So I'm going to talk around mainly 3 different types of imaging today, because these are the ones which are commonly used. As I say, there are lots of different types of images which we can image the front of the eye, outside of the eye, so on and so forth. But in terms of attending a retinal appointment or being assessed for potential inherited retinal disease, these are the 3 main things that you would have. Now, one of the reasons we dilate you during the clinic is to make your pupils big. It's partly to help us assess the eye, but also it helps us to get some pretty good pictures as well. We can take a lot of these pictures without you needing to be dilated, but ultimately it helps to get us better images, which is particularly important if you're only being monitored once a year or so on and so forth, or if we want to monitor very subtle changes, we want to get as good a picture as possible so we can make a decision really. Now, the first one we're going to talk about is fundal photography. So fundal, or fundus, basically just means looking at the back of the eye, so the picture of the back of the eye. And that's what it is. It really is just a photograph which we would see of the back of the eye. Now, a lot of these are taken if, let's say, you have diabetes, you would go for a screening appointment where you have these photos taken and you get pictures like this at the top, which is a normal and healthy eye. Now, this type of photo actually just looks at really the central part of the back of the eye, but this is where a lot of the important details are. So the optic nerve, the blood vessels, and the macula. And then you can see there's a bit of a difference to the one at the bottom, where on the outside, you can see these brown specks. The color looks very different. The nerve, instead of being a nice pinky outline, has got a much more of a whitish look, which is someone who has retinitis pigmentosa. Now, just taking that a bit further, the gold standard really in many eye units now is to perform what is called wide field photography, or usually what's called an Optos machine. And you can see in this picture that the important details might seem much smaller, might seem lost here, but that's because we're now seeing the entire retina. So we're seeing the entire periphery, well, almost the entire periphery. And this gives us a lot of very important information. And from that, we can then zoom in and have a look in a bit more detail. It's not a true image. This is sort of a reconstructed image. And at the bottom, you can just see a person's eyelashes there, which sometimes get in the way. These are very impressive machines. So these we're able to take images of adults, of children, even babies if we absolutely had to, if we position them carefully. So it's very useful to try getting a good detailed picture of the back of the eye. And this is why it's important being able to see the outside. So in this case, you might think that actually the central part looks reasonably okay, but you have lots of these changes on the outside, which are very important to see. So we would only be able to see this if we were examining you. If we had to ask you to look in very particular directions, we would have to be very careful with the lens. But here with a very quick picture, we have all of this information. So that first is photography. And we'll come back to that in just a moment. Now, the next picture or the next imaging modality I'd like to talk about is something called OCT, so optical coherence tomography. This has really revolutionized ophthalmology retinal treatment over the past 15 years or so. And almost without doubt, if you go to a retinal clinic, almost every patient or every person will have an OCT taken of the eye, if it's possible to take. And really, what is it? So obviously it's got a very long name, but it's useful to think of it really, it's like an ultrasound involving light, basically. So it's a machine really which shoots some light into the eye. It's near infrared light. It then measures the reflection of the light back, the scatter of the light against a reference to give you an image. It's a really great piece of equipment because this is non-invasive. Yes, you have to be able to position yourself. You need to stay reasonably still, not blink, and have to obviously position your head and neck. So sometimes it is not possible to do this. We do have portable types of these machines. They're not perhaps quite as good, but still nonetheless quite useful. It's non-contact, so nothing is touching your eye. It is fast, obviously painless, reliable, sensitive. There's no radiation involved here at all. So obviously this is why the eye is such a useful organ really, because it is optically clear. In other words, you can see out, we can therefore see in. So let's say if we compare that to other organs in the body, you know, let's say we had to look at your liver or kidneys, we'd have to do invasive tests, let's say like a blood test or biopsies, or you'd have to go into a CT or an MRI scanner, a CT scanner of which would result in radiation. The eye is very beautiful in that most of the things that we can do here, we don't even need to touch the eye, and they're taken extremely quickly. The other fascinating thing about taking images of the eye is that we can basically directly observe the central nervous system, and we can't really do that anywhere else in the body without you having to have an operation. So this type of image is really important, and it looks at the macula. So you can get different types of OCT which can look at your optic nerve. So if, let's say, if you had a condition like glaucoma, that might be useful, or other things. But for the retina, and certainly in the retinal clinic, we would always take a macular OCT. So this is looking at that central sensitive part of the retina in lots of detail, as we can see here. So that little dimple that you can see in the cross section and that little dark area in the center there, that's our macula, and this is what it's looking at. Obviously, small things, small tiny bits, tiny change of the macula can have quite a big impact on vision. So it helps us to ascertain functionally what your vision would be like, as well as helping the diagnosis. So we know that anything that affects the macula can result in straight lines appearing wavy, blind spots centrally or just off centrally, or just like a deep smudge like this if it gets quite bad. And when we take an OCT image, this is what we get. So if you look on the left here, you see almost like a black and white image of the back of the eye, and you see lots of green lines here. So this is the different cross sections it takes, and what we're interested in is the one right in the center, which is going through your macula, and in the center of the macula you've got the fovea, which is responsible for our really fine vision right at the center of the macula. And this is what we're interested here. So this is a picture of your central macula, your fovea. It is like a little dimple, so let's say a valley in between two hills, and that is normal. You can also just see, I'm not sure if you can see my arrow or not, just on top of this hill with the two dimples, you can see two almost little leaflets just moving off there. That's actually the back of the jelly at the eye. So that's part of the vitreous that you're seeing as well. So we can see things in a huge amount of detail. So much so, in fact, that we can almost separate each individual layer of your retina. So if we look back at that schematic we had, when we look at that diagram of all the cells in the retina, if the image is good enough, we can almost see all of these layers. So it is highly detailed. We get all this information in a very short space of time. And the important parts are, obviously, we want to check that the overall contour's okay. We want to check if there are any blobs in the middle, which I'll show you in just a moment. And also these layers at the bottom, these sort of three white lines, three white lines here are also very important. So the bottom white line is our RPE, the retinal pigment epithelium. This is the layer which is supplying the retina with nutrients. And above that here, we have the ellipsoid zone. So that is really a marker of your photoreceptors, so how well these cells are working. So we can basically see those in sort of that time point. And that's one of the things that we look at when we're assessing particularly inherited retinal conditions. We can see all sorts of different pathology and weird and wonderful things here. So I'll just talk through some of these. So again, on this picture here, you've got the normal OCT of the macula on the left. So this dimple, the valley in between the two hills. And then if you look at the one on the right, you see this almost looks like a mountain here with all these black sort of spaces, these gaps here. And you can see it's much, much thicker than the normal image. Now, these black spaces are fluid, really. So this is something called cystoid macular edema, which can be a feature in some retinal conditions, some inherited retinal conditions. And this is quite a severe case, but as you see, because this is such a sensitive part of the eye, this will have quite a dramatic impact on the vision. So edema in medicine basically means fluid or swelling. So that's why your eye doctor might say there is swelling at the back of the eye, or there is no swelling at the back of the eye, or the swelling is getting better. That's what they're talking about. The macula obviously referring because it's right in the center, and cystoid, it just means the pattern of the edema there. So they might just call it macular edema, or let's say if you have diabetes in the eye, you can sometimes get diabetic macular edema. Now, before we had these images, we were having to basically try and work this out ourselves with our lenses in clinic to see if we can see the swelling there, but we couldn't quantify it. It was hard to tell if it was getting better or getting worse. But here we can actually see it, and we can take repeated images over time, which gives us an idea of how things are progressing. Similarly, it's also revolutionized the treatment of wet macular degeneration. So again, we've got the normal scan on the left. On the right, you can see this is very different. You can see, firstly, you've got these black spaces again. So that's fluid there, that's swelling, that's edema. And then underneath, instead of having these nice straight three white lines, you've got all this ruffled, rugged area, which is usually due to this network of blood vessels underneath there, which is causing the problem here. So again, we can now monitor the progress of wet macular degeneration over time. So let's say if you're having treatment for that, we'd like to see these black spaces go away and disappear in time. That usually correlates with you noticing an improvement in your vision. The other thing is that we can take different types of these scans. So for this one, this is just an example that actually we can go beyond the retina, we can go a bit further down. So we can actually look at the choroid underneath the retina in certain cases. So we are basically able to see most of the layers of the back of the eye here, which is really very useful. Now, how does an OCT help with inherited retinal disease? Well, firstly, it helps in the diagnosis. It helps to assess severity, helps us to monitor progression, and also look for complications. And not only can we just look at the scan, we can actually take physical measurements. So if the scan is good enough, we can measure that on the software which is associated with the scan, or we can do that manually ourselves with some other type of software. And this becomes important not only to, not only just for a patient or a person at their clinical visit, but also if we want to try and think about a treatment, obviously we would need to test that in a clinical trial, and actually being able to take these measurements successfully is really important. So this has really helped us to do this. And two of the things we look at are central retinal thickness, so the one on the top there, usually that's about under 200 microns, so 1/5 of a millimeter, and then also the ellipsoid zone, so this one here in the middle, and also at the bottom. That's a person at the bottom has just got a slightly longer eye, which is why it's a bit more bowl shaped as opposed to it being flat. And these parameters are really important to be able to measure over time. And actually we can then basically figure out the natural history of the condition. So let's say if you had a particular type of retinal problem, we can take measurements from lots of different patients over time and compare them. And then we can say, well, actually this progresses very quickly. This measure will drop in a few years. We've got this window to treat you. Or we can say, actually, no, this tends to progress very, very slowly. We've got a large window of treatment, or you don't necessarily need treatment. And that's why, and it's also important when you counsel someone when they come to the clinic to say, well, actually, because of all of this information that we have, we actually don't think that this is going to progress very quickly and you'll stay stable over time. And again, one of the other reasons is cystoid macular edema is a feature of, let's say, retinitis pigmentosa, a form of inherited retinal eye disease, which can happen. It can be quite frequent. It depends upon the type that you have. But you see, this is the same patient, and this is what happens when they're treated in some cases. So at the top, this is untreated, and then we've given them some drops over a few months. It's not completely gone away, so it's not gone back to that valley and the two hills, but it's certainly much better, and we would hope that their vision improves from that. Now, the next one I'd like to talk about is something called fundal autofluorescence. So this is an important tool. You might not necessarily have this at each clinical visit, but certainly if you come to a specialist clinic, you would be having this, because it provides a lot of information. So structures in the eye have fluorescent properties. I mean, it's not to say it's glow in the dark, but basically if you were to shoot a particular wavelength of light at the eye and you use a particular filter, you'll be able to measure a background fluorescence. And you see this photo here at the bottom. It almost looks like a black and white image, but it's basically a type of autofluorescence from the eye. And what we're measuring here depends upon the type of light that we use. So most of the time we use a short wavelength, let's say a blue light or a green light. This measures something called lipofuscin. So basically all that is that this is a substance which is in the back layer of the retina, the retinal pigment epithelium, so the single layer at the back. Being able to measure this is important, because in some cases, if increases in quantity can be associated with some conditions, or if there's no autofluorescence, then that's also important to know. You can use a slightly longer wavelength as well to look at melanin, so a slightly different substance again in the RPE, but ultimately we can think of this tool as looking at the health of the retinal pigment epithelium. So you might think, well, why do we need to use this sort of black and white when we've got it in color? Well, it's a good question, but I'll show you an example here. So this is a person who has Stargardt disease, and on the image on the left, you can see is a photo. So you might be able to think, well, just next to the nerve where the macula is, there's some few very subtle changes there, but I'm not sure. There's some yellow things just on the outside. But actually, when you look at the autofluorescence, this gives us a lot of very important information. So you see these white specks in the circles just around the blood vessels, and where the macula is, you see this big black area just showing where actually there's been some damage to the macula there, which therefore provides us with a lot of information. You can have different patterns as well, so it helps us with diagnosis. So in Stargardt, you might have these flecks. In choroideremia, you might have lots of different areas or patches of atrophy. So this is, when we say atrophy, this is part of where the retina is very thin, so it's unhealthy, and sometimes might not even be there. And then also in macular degeneration as well, it can be very useful, because actually if there's a lot of what we call central atrophy, so a central damage, even with the treatments we have at the moment, unfortunately we can't restore that. The other thing is that this can also be used to take measurements. So in certain types of retinitis pigmentosa, you can see these rings. And these, again, this is measuring lipofuscin in the retina. And when you see these rings, these are areas where actually the cells in the retina are unhappy, they're not healthy. It's not to say that they're dead, but actually they aren't normal. And actually, if you quantify these over time, you can see how the condition progresses. So you can take measurements and see if that ring gets smaller over time, which corresponds to the disease progressing, as an example. And this is what you can see. This is all in the same person here, with a CNGB1 related retinitis pigmentosa. You can see it in 2017, the ring is actually quite wide out, and then it slowly gets a bit smaller every couple of years. And this, again, on the picture on the right there, just illustrates the measurements that we can take from this, which can then help us in terms of understanding the natural history of the disease, helping us then in clinical trials to see if a treatment works or not. And there are lots of different patterns of autofluorescence here, so it varies very, very widely, even within the same condition sometimes. So let's say in the top left, you see lots of speckled areas on the outside and then a bit more speckling just in the center. The one top in the middle there, there's a lot of what we call a dark spot in the middle, so that's atrophy of the macula. And the top right, this is towards end stage retinitis pigmentosa, where there's basically a lot of the retina has been affected and there's a big central smudge or atrophic area in the macula, and similarly on the bottom ones as well. Finally, one I'm just going to quickly just touch upon is angiography. So this does form part of our imaging repertoire. It is not used as frequently, and many patients who have been diagnosed with inherited retinal eye condition might not have had one of these. So that's because sometimes it doesn't help the diagnosis. It's a little bit more invasive. So basically, we have to put a little cannula into your arm and inject some dye, so some what's called fluorescein dye, so orange dye, into the arm, and then we take photos of the back of the eye at various time points so we can see the dye moving through the blood vessels, and this can give us some important information. So let's say if we're a bit uncertain of the diagnosis, whether this is a blood vessel problem, whether this is an inflammatory problem, whether this is a genetic problem, this can be quite useful. And this is just really a snapshot of one of the picture that you might see. So at the bottom of the picture here, you can see the squiggly lines are white, so that means the blood vessels are working. There is dye flowing through the blood vessels. At the top here, you see some of these squiggly white lines, but there's also a black line where the dye isn't flowing. So this is a blocked blood vessel, so a retinal vein occlusion. And there's also some unevenness of the dye at the top there to suggest that part of the retina doesn't have as good as blood supply as the bottom part of the retina, and therefore is probably not functioning or seeing so well. So this is just another example of one of the things that we can do, but as I say, it's a bit more invasive. You do have to have the fluorescein injected. That can make you a little bit itchy, a little bit sensitive to light, and sometimes you can have a bit of allergic reaction to it, although that's very uncommon. But it's one of the things we can also think about doing in the clinic if needed. So in summary, this is really just it's a huge topic, and you could spend an entire series of lectures just on one of these imaging types alone. But imaging has really revolutionized the treatment of eye conditions in the past 5 to 10 years. It helps us in the diagnosis, to monitor your progression, to really look for any complications or other problems that might be associated with it, and helps us understand the natural history of your eye condition. It's also used, obviously, it's one of the tools that we use. Obviously, we take into account your history, looking at you, examining you on the slit lamp, family history, genetic testing, other things we do beyond that. But otherwise, thank you very much for listening. I know that was a lot in a very short space of time.
Thank you very much, Daniel. That was brilliant. I learned so much from that. That was really clear. So thank you very much. I really enjoyed your descriptions of all the images as well. So I think, yeah, that was really good. We've already got a question in the Q&A box, so I'll just read that one out to you. I'm just going to ask Matt to keep an eye on people's raised hands if possible, please, Matt, and shout if anybody does raise their hands. So just a reminder, you can type into the Q&A box, but if you would rather ask your question live, do just raise your hand using the methods Matt described at the beginning, and we will ask you to unmute, and then you can ask your question live. So the question we've got says, as well as using serial images alongside functional changes to monitor progress, can any images or dyes show rate of change at that time the image is taken? So perhaps by showing abnormal processes, so this person said, by showing abnormal metabolism in the RPE. If not, can you imagine something like that in the future? Thank you. That's a very good question.
Yes, that is a good question. So there are, yes, we can to an extent. So as for example, with OCT, we can perform something called OCT angiography. So that looks structurally at the eye. It also gives us an idea of the circulation in the retinal system at that particular time. It's a bit of a newer modality. It sometimes is a little bit crude and a little bit hard to interpret, but it's certainly very useful. And it was certainly very useful in a number of situations. I suspect imaging is very much the hot topic in ophthalmology at the moment. And in my career, I've been doing this for 10 years. It is transformed and changed so much that it's only going to improve in the future. So the short answer is yes, certainly. We're always looking for ways in which we can get as much information as possible at a single visit, as opposed to having to watch things and see changes over months or years.
Excellent, thank you. I just thought of a couple of questions. So clearly, all of these images put together, often they're quite distinct for different conditions. When you look at a set of images, can you confirm, before you get as far as genetic testing, do you know just by looking at somebody's images that their condition is genetic? That's
a good question. In some cases, yes. So it really depends. There are certain features which would strongly support, let's say, a genetic eye condition. So a lot of the time we can. There are always those which there's a big unknown. So, for example, we have lots of patients who we think have genetic eye conditions, but all their genetic testing comes back negative, and then we have to think, well, actually, have we misinterpreted the image, or do we just not understand the disease? Are there limitations in our genetic testing? Usually, again, not always, but usually we have a very good idea of the diagnosis based upon your imaging. There are some cases with genetic eye diseases or retinal diseases where the imaging can look very normal, or let's say in children where it's particularly difficult, or we struggle to get particularly good images, in which case we then have to rely on other things. So clinical judgment, having a look, or looking at electrodiagnostic testing, so measuring sort of electrical impulses from the retina, from the eye. Okay, I just saw a question I think pop up in the chat box. I don't know, and I seem to have lost it again. So if you were that person, I'm really sorry. Would you mind typing it into the Q&A box again?
I can read it, Kate.
Oh, can you? Can you see it?
I've got it here, yeah. So question from James is, how far are we from being able to look at the retina and know what gene defects someone might have? Is AI being used to decipher this?
Yes, a very good question. So we're probably not that far away from it at all. So there's been a lot of work by some of my colleagues at Moorfields using AI techniques, DeepMind and so on, which have been validated for some other eye conditions. One of the things we're looking at is trying to validate it for inherited retinal problems. One of the issues you could argue that these are rare diseases. So actually, to be able to develop this, we need as much data as possible. But actually, Moorfields or the big hospitals in the UK and the world are able to do this. So the answer to that is yes. It's not going to be far.
Okay, and I think James has got another question. Matt, are you?
Yeah, so James follows up with, do we know what changes have been observed in the retinas of people who have been given gene therapy, e.g. AAV gene vectors for RPE65?
As in, do we know what changes they've had?
Yeah, do we know what changes have been observed in the retinas of people who have been given gene therapy?
So that's a good question. that one I'm not involved in. I don't know off the top of my head, so I don't know the precise changes that have occurred there. Most of the metrics that we're using at the moment are usually ellipsoid zone length, purely because it's not influenced by things like what's called cystoid macular edema, which can adjust the thickness, or epiretinal membrane, or most other things. But I'm not sure off the top of my head, sorry.
That's okay.
We have a hand up.
Oh, okay.
We've got a question from Perm. So Perm, I'm just going to allow you to speak. So you may just need to unmute yourself.
Hello, thank you for allowing me to speak. I have a question for Dr. Johnson. What it is, earlier on, I was actually diagnosed with just fluid through a routine eye examination, and this was just with ordinary lenses, then referred to the hospital. So that actually didn't actually show early signs of retinitis pigmentosa, which later I've got genetic testing for Usher's 2A. Now, with the earlier stages, can you tell how thick the fluid is with your imaging now that you use? Because you were saying you can actually tell what type. And can you actually see any marginal changes at the next review that you might have if the fluid has gone down or not to an accurate degree of either 20%, 30%?
So yeah, that's a good question. So we can take very accurate measurements. We always have to bear in mind the error on these measurements. We're talking about very thin measurements, and also we need to have the OCT taken in the same sort of orientation, if that makes sense. But usually at every eye appointment, if you've got cystoid, so you have cystoid macular edema from USH2A mutation.
Yes, yes.
So yes, yeah, no, we can monitor that. It's also one of these things where it can fluctuate a bit, and we sometimes say that to patients. So obviously, if we're seeing an obvious trend down, we can say it's getting better. Sometimes, we might be talking 5-10 microns difference between visits. We also have to be very careful when we measure those areas on the scan to make sure we're measuring in exactly the same place. So we just have to be very, very careful.
See, the thing is with treatment, obviously you give AZUP drops or other drops as well, or Diamox tablets.
Yeah.
Have you looked at any alternatives other than, because I'm taking AZUP and there's only been a bit of a marginal change, and the clinicians are really kind of reluctant to put me back on. I'm just thinking like the fluid doesn't manifest in the left eye, but it's manifesting quite strongly in the right eye, which is a weaker eye. Is that just down to the mutation, or is it just down to like it's basically the macula's bleeding or leaking at the back? So
yeah, so it's a very good question. So cystoid macular edema is a condition which is associated with lots of different eye problems. So you can get it after, let's say, cataract surgery. You can get it from a blocked blood vessel, let's say a retinal vein occlusion, or an inflammatory eye condition. In many cases, these inflammatory causes can settle down with steroids. So steroid eye drops, even injections or implants into the eye if needed. For reasons we don't necessarily fully understand, the cystoid macular edema or the macular edema in retinitis pigmentosa is slightly different. So for example, when you have the AZUP drops, or when you have dorzolamide or oral tablet Diamox, the cystoid macular edema can respond to that in retinitis pigmentosa, but actually in other forms of cystoid macular edema from, let's say, cataract surgery, so on and so forth, don't respond to that. It's unusual. So a lot of patients unfortunately don't respond. It all depends upon the type of retinitis pigmentosa you have as well. So we would tend to go around the course of drops to see if they work, or even tablets if you absolutely had to, but sometimes unfortunately it doesn't work, and again we're not entirely sure why.
Okay, thank you so much, Doctor. Your talk is absolutely mind-blowing. Thank you, I've learned a lot.
You're welcome.
Has anybody else got any questions they would like to ask? Matt, have we got anything in the chat or any more hands? I was just going to say, while people are having perhaps another little think, when you do imaging in natural history studies and you do kind of serial imaging, presumably in those natural history studies, you're also talking to the patient about their functional vision and what they're experiencing from a vision point of view. Is there kind of a clear correlation between measures you take in, for example, an OCT scan and somebody's actual experience of their vision loss? Or is it very, very personal and far too difficult to sort of tie together?
That's a good point. So obviously, a person's vision to themselves is very subjective. It's influenced by lots of things, so not just health of the eye, the brain, the nerves, so on and so forth, amongst a huge number of other things. We know that there are certain features in the retina which means you're likely to have better, or certain features we can measure which are likely to correlate with better vision. So for example, if your macula is intact or there are very few change there, you'll likely be able to see much better than someone who hasn't. Or let's say if your ellipsoid zone at the center is normal on the scan, you're likely to have much better vision. It's when we terms measuring the periphery is a bit different. So obviously that relies on visual field tests on other things. So from the retinal, from these sort of scans, as we've seen here, it's not really a way of let's say basically judging what a peripheral vision is like. But yes, so in essence, yes, they should correlate. Again, that's also quite a tricky thing to measure. There are certain questionnaires and quality of life scoring which are included in trials or can be included in natural history studies, which have lots of these influences. Yeah.
Thank you. I was just thinking about what the regulators are looking for, and perhaps what NICE are looking for ultimately is perhaps the impact on the person's quality of life or their day-to-day life. And but obviously also these measures are so important because they're objective and they're accurate. So
yes,
it was just interesting from that point of view. Have we got any further questions? I can't see any in the Q&A box. Have you popped?
So we have another one come up in the chat. So it's more of an eye health question. So for people with inherited retinopathies, apart from not smoking and eating a balanced diet, is there any other lifestyle advice for making your retinas, or to keep them as healthy as possible?
So one thing we would always advise is protect them from the sunlight. So make sure you have a good UV filter on your glasses. Make sure you're wearing sunglasses out in the sun. That's quite important. We've got, we've seen this already, we've got a website which we've created, gene.vision, which has a lot about this, which talks about, I mean, many of the things you've touched upon there, but certainly light is the important one, we think.
Fabulous, thank you.
And somebody's just said in the chat, thank you very much for such a clear and informative talk. And it certainly was that. Matt, I think if we have no more questions typed in and no more hands up, I'll hand back to you.
I have a question. So one of the first images you showed, Daniel, I think it's one of the photography images. It looked like there was like a forest of broccoli on the outside of the eye. What was that?
Yeah, so that's that was the bone spicule pigmentation, so which you can see with certain types of inherited retinal conditions. So it's a feature of retinitis pigmentosa when you see these sort of specks just in the periphery there. So you see that, you tend to see narrowing of the blood vessels, the nerve can be a bit pale, but yes, certainly when you see that, sometimes you can see it in a full circle, sometimes you just see it in certain areas, or it can be really very subtle and easily missed. Sometimes it'll also be mistaken for scarring from previous inflammation or even laser treatment at the back of the eyes as well. But yes, that's a feature of retinitis pigmentosa, or a form of.
Fab. It always amazes me, particularly with the photography, how beautiful the pictures actually are. For considering some of the things that kind of people are experiencing with sight loss. I know I've seen some amazing pictures of when I've had my eyes photographed, and I've always asked for pictures to put them on a t-shirt or something, but they've I've always been told no, you can't have those. Daniel, thank you, that's absolutely fantastic. And somebody else has said you'd also like to say thank you, it's been great. So last call for any questions, otherwise we will wrap up for the evening. Certainly really enjoyed the session, Daniel. Thank you very much. So just a couple of things to to tell everybody about just whilst you're here with us. So obviously a huge thank you to Daniel for such a fantastic presentation. And thank you to all of you who've joined us for this presentation this evening. As mentioned at the beginning of the evening, we are planning to hold at least one webinar every month. Over the coming months, we've got topics including Stargardt disease, Usher syndrome, some technology, and we will be joined by somebody from the Department for Work and Pensions to talk around the Access to Work scheme, which I know is something which is interesting a lot of people at the moment. I also wanted to remind everybody that Retina UK are currently collecting responses for our second sight loss survey. So results of this survey allow us to better understand our community, and in turn allows us to ensure that we are delivering the right services. We can influence the right people with the latest data, and ensure that we're funding the right kinds of projects. So this is a great opportunity for you to have your voices heard. The survey takes around 20 minutes to complete and is open to anyone living in the UK with an inherited retinal dystrophy. You can complete the survey either online via our website, so that's retinauk.org.uk. You can contact our office for a paper copy, or you can even have it done over the telephone. So for more information, you can have a look on our website or contact the office team on 01280 821 334. Again, to remind you that Retina UK is a registered charity. We receive no government funding, and we rely on our wonderful supporters, people such as yourselves, to raise the funds needed to provide our vital services and to invest in groundbreaking medical research. And so there are some great ways that you can support us during 2022. You could challenge yourself to run, walk or cycle in one of the many events taking place throughout the UK. Our fundraising team are here to help you with some expert support and guidance, as well as offering places in prestigious events such as the London Marathon, the Great North Run, Ride London as well. So you can visit retinauk.org.uk/2022 for some more information on that. Or you could just do some simple fundraising with your colleagues at work, or ask your employer to select Retina UK as their charity of the year. So if you want some more information about this, you can call the fundraising team on 01280 821 334 or email them fundraising@retinauk.org.uk. So finally, we will be sending out an email over the next couple of days, which will have details of where you can rewatch or listen to Daniel's presentation, and how you can book onto our other events. We'll also be sending out a short link for some feedback on today's session. We really do value your feedback, and allows us to plan future events and make sure we're getting the right things for our audience. So once again, thank you ever so much for joining us. Thank you to Daniel, and we bid you all a good night. Thank you very much.